Welcome to the program. Today we're here to talk about concerns about our youth and how we can be helpful to them. I'm Dr. Victor Fornari, Director of Child and Adolescent Psychiatry at the Zucker Hillside Hospital and the Cohen Children's Medical Center of Northwell Health. I'm here together with my colleague, Dr. Vera Feuer, who's Associate Vice President for School Mental Health. And today we're going to be talking about concerns that we have regarding our youth. Certainly, we know that during the past 17 months of the epidemic, the pandemic, children have really been very impacted, and we've seen a dramatic increase in anxiety, depression, and suicidal behavior amongst our youth. And today we really wanted to have this discussion together to see how we can be helpful with our youth. So Dr. Feuer, to begin, could I ask you, could you help dispel some of the myths about suicide and our youth?
Yeah, thank you, Victor. So some of the common myths that we hear or that you might hear is that kids are making suicidal comments just because they want attention. And that is a very important myth to dispel because really, even though it might be technically true that they want attention, but the question we should always ask is why are they needing that attention? Is it because they're depressed? Is it because they're suffering? Is it because there's something going on with them that maybe they never told anyone, never revealed to anyone, and now it's exhibiting in this way with these difficult thoughts. So really, it's very important to never dismiss when kids are reporting these thoughts, but always try to go deeper and really understand what it is that's going on with the youth.
Do you think that many people believe that children and adolescents do not become suicidal because childhood is supposed to be a carefree, happy time?
Right, that's another very common myth that people assume that kids, what are the things that they have nothing to worry about, they have no responsibilities, what it is that they are so stressed about. It is very common that we'll hear parents say, I don't understand, what does she have to be depressed about? Her life is easy. And that is, again, very important to contend with dispelling that myth because it can be very harmful and very invalidating to the kids to whom the problems that they're dealing with are very, very real.
And what is it that we actually know about the prevalence? How often do youth actually report suicidal thoughts or behaviors?
So actually we know quite a bit, and unfortunately the numbers are not very encouraging in the recent years. Prevalence of suicidality has been on the rise for over a decade now. We have a yearly survey that the CDC sends out to high school students, and according to that survey, almost 40% of kids actually think about suicide and report that they have had suicidal thoughts in the past year, which is very, very high and has been higher each year that they do the survey. And of those, about 20% actually attempt and do try to, in some way, harm themselves. And of those, about 10% actually harm themselves so seriously that they need some sort of medical intervention. And the last year that we have numbers for 2019, we had over 2,000 completed suicide in that age group, in the high school age student.
And how prevalent is completed suicide throughout childhood and adolescence? And I know that oftentimes the Center for Disease Control really reports it up till age 25. So what do we know about completed suicide in children under 12, adolescents 12 to 18, and then the group 18 to 25?
So the prevalence in all of those age groups have been increasing, and what's alarming is that one of the biggest increases has been in young adolescent girls. So the 10 to 13-year-old age group had a very significant increase in the recent years. And we also know that suicide has become the second leading cause of death in all three of these age groups that you mentioned. And with that, it's really a sobering statistic to think about that suicide, we lose more kids to suicides and young adults to suicide than we do to all other medical illnesses combined.
Now, I wonder if that's a fact that certainly very sobering, if people really understand how prevalent a problem suicide is amongst our young people.
Right. I think it is important to stress the prevalence because it can tell us that it is really a public health crisis. This is really, again, other than accidents, it's the only other thing that's the second leading cause that we are losing kids to and young adults to, and now kids as young as 10.
So we've heard a great deal about the impact of the COVID-19 pandemic on mental health throughout the population. Certainly, people have been stressed for so many reasons, social distancing, social isolation, food insecurity, housing insecurity, lack of attending education and remote learning. What are some of the reasons that you think help us to understand this increased numbers of youthful suicide?
So I think even before the pandemic, we've had issues that our youth had to contend with. There's been so much tension in their life with technology changing their world and changing our parenting practices, with struggles with the environment, many other things that you mentioned, food insecurity and things like that. Even before the pandemic, these were issues, healthcare disparities, all issues that youth have been struggling, balancing and managing and dealing with. And the pandemic sort of put an extra layer of stress on all of that and really further emphasized and further pushed people that were at risk deeper into their risk and widened disparity gaps and things like that with education and virtual education not being as available to all the same way, school districts having very different ways of managing the pandemic or very different resources to be able to manage the pandemic, families going through very different experiences through the pandemic. Like we have said, it's been the same storm, different boats, and everybody's experience is very unique. But what we have seen is that there has been a general increase in adults and kids in depression, anxiety, that social isolation, the education loss, the demotivation resulting from the isolated virtual learning are all things that we are seeing kids coming in with, complaining about, and really seeing a true impact on how that had affected them during this time. And as you know, and I would like to hear more about that, another particular group of kids that have been affected are kids with eating disorders, and
Right.
you have seen that at the hospital.
We've seen a dramatic increase in the number of individuals coming with serious eating disorders, the number requiring emergency care, hospitalization care, and actually the severity of the eating disorder being more severe. So we've seen this dramatic change. I understood there's, in some populations, perhaps young adolescent girls, maybe a 50% increase in referrals to the emergency room for suicide attempts. Has that been your experience?
Yeah, we definitely have seen an increase, especially during this year in 2021. We have seen more kids coming to the ER, reporting depression, reporting suicidal thoughts. Also, somewhat younger kids than usual coming with these thoughts, reporting these thoughts, we have also seen, and again, on the medical floors of the hospital, as you know, we have seen many more kids requiring medical intervention and medical admission because of the seriousness of their attempts.
Now, so we certainly want parents, educators, and the community to understand about these serious concerns that children have. What are some of the risk factors that we believe are important for parents and educators to know to help identify who might be at risk for depression, suicidal thoughts, and concerns regarding suicide?
Yeah, so the risk factors are well known and well established. Most serious risk factor for trying to hurt oneself is a previous attempt. So history of suicidal thoughts, suicidal behaviors, self-injurious behaviors can be a risk factor as well. They in themselves do not they're not the same as suicidality. Often children and adolescents self-injure because it's an expression of how they feel, and it's a way of coping, and it's a way of dealing with what they're dealing with, although very maladaptive and harmful.
But I imagine both parents and educators, when a child self-harms, have a hard time distinguishing when is this suicidal and when is this non-suicidal behavior, and how to make that distinction in order to keep the child safe.
Correct. So for that reason, whenever these behaviors happen, those are red flags, and those are reasons for an assessment and for evaluating their risk further to see, what it actually means. Other things, depression, severe depression is certainly a very important thing to mention. And when kids are depressed, they are not necessarily depressed the same way as adults are. Their symptoms might be very different. Kids are very good about hiding their symptoms and keeping everything inside and not really sharing with their environment. And on the surface, it might look like they're doing okay, but parents should be on the lookout for red flags, changes from the baseline. Sometimes depression in kids comes out as irritability and anger and behavioral issues. And those are, if they're really off from baseline, off from the usual on how your child behaves, how your student behaves, should be an alarm bell as well.
Well, I think for parents and educators, if their child or the student is depressed, they may identify them as a concern to make certain they're not suicidal. But my experience has been also if they're anxious. And I don't know how well understood parents and educators are that children who are and adolescents who are highly anxious are also at increased risk for suicidal thoughts and behaviors, sometimes because they're actually feeling so panicked that it's an intolerable feeling. So I wonder what you've seen in the emergency services.
Absolutely. So anxiety is definitely a big acute risk factor, and unmanaged anxiety is a big acute risk factor, because that restlessness, that feeling of like I can never be calm, I can never rest, I can never relax, can really be very upsetting and very difficult for kids to manage and cope with, and can definitely lead to suicidality. Panic attacks, frequent symptoms like that can also certainly lead to that. And again, important for parents to know that anxiety in kids also doesn't always manifest the same way. And it could come out again as behaviors, as acting out, as being angry, irritable, very difficult even to tolerate in the family sometimes. But we really need to be patient with the kids and really understand what it is that's driving the behavior, what it is that's driving what's underneath it.
Now, we know that each summer, as children prepare to return to school, a certain number of kids will really become school refusing when schools open after Labor Day. Now, after having been on remote learning for over a year, there's a great deal of concern that many youth might really have a hard time, particularly if they're anxious and depressed, returning to school. So what can you share about thoughts about concerns about school refusal once schools reopen in September?
Absolutely. Thank you for bringing that up. It's really something that we think about a lot, about how to prepare for it. We've been discussing it with schools. Schools can and educators can work on trying to identify ahead of time if these students they know who has been in virtual learning, maybe who had a hard time being in person learning even before the pandemic. We can expect that they're going to have an even harder time, because anytime you avoid something that you're afraid of, in this case being in-person learning, it will just heighten the fears and make the anxieties worse. So we can expect, and parents can expect, that if their child had a hard time with in-person learning, they're going to have an even harder time after a long hiatus, and that anxieties about the pandemic and safety might still be on these kids' mind in addition to their usual anxieties. So we all need to prepare for that. My recommendation is for parents to start talking about it well ahead of school starting, make it a topic. If you really are expecting that there's going to be a hard time, even practice putting out clothes, choosing things, making decisions that might lead to anxiety the morning of. Try to make them the day before, the week before. Practice it, talk about it, because even that sort of exposure to thinking about the anxiety-provoking event can help decrease decrease the anxiety and lessen the impact once they actually have to do it. And then we can also expect, as you know, when the exposure happens and anxiety shoots up, that kids will protest, that kids will escalate their behaviors. And the key to that is really just making sure that we're consistent and calm in messaging the same message over and over again about what the expectations are, and then also validating their feelings and their anxieties and really helping them problem solve ahead of time for the day. You know, what it is that you're nervous about, what do you think might happen, how might you react to that? And when kids are feeling prepared to deal with the problems that come their way and are getting consistent messaging about it, it's going to be much easier for them to navigate.
Now, of course, we know that oftentimes children who are highly anxious may have parents who are also highly anxious. So when the child refuses to go to school in September, what do we expect? I imagine some parents will be asking the district to keep their kids in virtual school because they too are anxious about their kids returning to school.
Right.
And so I think we have to recognize that parents and educators have to be mindful that perhaps parents have to really be aware of their own level of anxiety, because that may be a risk factor for their child's anxiety themselves.
Yeah, absolutely. And that's a great point. And I think it's also important for parents to understand that the reflex to want to save your child from the exposure is not necessarily the best thing for your child on the long run, because at some point in their life, they're going to have to contend with and navigate this anxiety and develop coping skills of managing it in social situations. And what better time and place to learn that than with the loving support of your family and school that can help accommodate and support you. Much easier to do that now than having to do that later on in life.
But we understand that with increasing concerns about strains of the COVID-19 virus, including the new Delta virus, the concerns that many youth, of course, are not vaccinated, particularly the younger ones, that many families still are going to be concerned about allowing their children to return to in-person learning, even though it's currently being recommended. And I think that we're going to have to figure out as we proceed how to best help these families when they too will be equally avoidant of in-person learning because of their own anxieties.
Right, absolutely. And I think that does bring up the topic of, you know, how do we fortify families and kids and fortify resilience in them? And one of the most important elements in that recovery from this traumatic 16, 17 months is the feeling of safety. Our feeling of safety has been so shaken. So when we're talking about re-entry to school in September and re-entry to regular life even now over the summer, you know, it is really important to remind ourselves how far we've come in the pandemic. What are things that we know now that we didn't know 18 months ago about how to be safe and how to keep ourselves safe and how far science has come. And it's really important to remind ourselves of that as parents, as educators, and then help our kids understand that and having them understand what their own role is in keeping everybody and themselves safe.
Right. So generally, we like to think of youth as resilient. On the other hand, you've reviewed some of the risk factors. What do we understand about some of the things that protect kids so that they don't develop depression, anxiety, and suicidal thoughts? What do we know about those factors?
Yeah, so protective factors are numerous. Of course, people who have coping skills and are resilient and are able to deal with stress and navigate it are always more protected. Kids that have family support and real social support around them, friends, church groups, spiritual groups, extracurricular activities, all those things do matter and make a difference for kids and youth. Kids that are perhaps struggling with mental health issues but are in treatment and getting help and have therapeutic relationships. People who have responsible adults in their life in general that can support them. And that can be a teacher, that can be an educator, that can be a therapist, a primary care physician, physician, but somebody that really is there for them and is there for them as a support is a really important protective factor as well.
Now, we certainly are aware of the prevalence of so many adverse childhood experiences that our youth are exposed to. This is not new to the pandemic, and we know that the base rates of adversity, whether it has to do with child maltreatment at home, witnessing domestic violence, parental mental illness, parental substance abuse, even prior to the pandemic, our children and our adolescents are exposed to a significant amount of adversity that can put them at risk, even though hopefully many of them will be resilient and will have some of the protective factors that you've just outlined. But I think parents and educators need to be mindful that when these adverse experiences exist in the lives of these children and adolescents, that it puts them at increased risk and really something to be very cautious about.
Right, absolutely. And I think what's also important for the public to understand about adverse childhood experiences is that we know by research that it's not only a risk factor for future mental health problems, it's a risk factor for physical illness in adulthood, cardiovascular disease, obesity, many others, cancer. And it is really important for us to be mindful of that and understand that the importance of helping these kids navigate this early on and developing coping skills and resilience will be protective for them in the future in terms of their not only mental health, but physical health outcomes.
Now, I will say now, having worked with children and adolescents now for more than 3 decades, that it's not long ago that the field questioned whether or not children and adolescents could become depressed. We've now come to appreciate a great deal that children do become depressed, that adolescents become depressed at an alarming rate, as you've mentioned earlier, and the relationship between those mood disorders and suicidal behavior. But I think it's just important that we just remind parents and educators that depression is an illness that does occur in childhood. It occurs at higher rates in adolescence. Oftentimes there can be a family history of a mood disorder, and it doesn't have to be necessarily a parent. It can be a grandparent, it can be an uncle, a sibling, but parents need to be aware that family history is also a risk factor for the development of mood disorders, and something for all of us to remind parents and educators that recognizing that these are serious medical problems and they require medical attention.
Absolutely, and it's so important. And I think one encouraging things that we are seeing about our youth is that the conversation around mental health has become a lot more normalized. We see that with many kids. They talk about it with ease. They learn how to name their feelings and emotions. New York State having a mandated mental health curriculum in school, I think, is helping in terms of breaking down the stigma around mental health, and that is encouraging to see, with the many things that the kids are suffering from. At the same time, we're also seeing them seeking help and reaching out for help at higher rates and verbalizing that they are dealing with these issues.
And I think it's important we remind parents and educators that there is no health without mental health. And this is a conversation that is occurring today because during the pandemic, feeling anxious, feeling depressed has become normal. It's more than 50% of the population that's struggling with these issues. And once it's normal, then it should be part of our conversation that in order to feel well, people have to address that. And the other thing that I think is critical is that we're getting through this pandemic. We're certainly trying to be calm, optimistic, and really demonstrate that we are going to all get through this together. However, we also have to accept and recognize that the psychological impact of the COVID-19 pandemic may actually be even greater than the medical impact. And of course, the medical impact has been enormous and devastating already, with over 4 million lives lost that we are aware of, serious numbers of individuals who have serious long-haul syndromes after having had COVID. And so I think the fact is that the psychological impact is even greater. And I think more and more we want to remind parents and educators that there is no health without mental health. And when there's a concern about anxiety or depression in a youth, really to recognize that this needs to be addressed, both for the parent as well as for the child.
Right. Absolutely. And the impact is not only greater, it's also going to be longer, because in addition to the medical impact that was the biggest early on and is still going on, but is, started tapering down, at least here in New York, the mental health impact continues to go on and on and on. And that is also because we still don't know. There's still so much that we don't know. And that level of uncertainty, and again, that shaken sense of safety is still lingering and is going to continue to have an impact.
Of course. So what can you tell us about your experience with providing clinical services for youth in crisis, urgent services, emergency services? We know that these services are desperately needed in the community, and you've been working closely developing them and monitoring them, supervising them. What can you tell us about your experience over the past 2 years since the development of the pandemic?
Yeah, so our emergency volume, again, it's similar to what we mentioned early on. This has been increasing for decades. We have been seeing kids coming more and more to the emergency department with mental health issues, partially because there's sometimes no alternative, and accessing services in the community can be difficult for families, and partially because, again, the issues are increasing and kids are coming forward with it more often. So this has been further emphasized in the pandemic, and as the pandemic progressed, the volume has increased tremendously. Like you mentioned earlier, same as with eating disorders and with kids admitted to the medical floor. In the emergency department, we also have higher acuity, so kids are coming in, especially during the lockdown period, and immediately after. The kids that were coming in were obviously delaying care for a while, being afraid to come to the hospital. By the time they made it, they were much sicker, much more acute. Now we're seeing just high volume, high acuity, and we do have urgent care services in our hospital, which has been very helpful because it does provide an alternative to the emergency department.
So, Dr. Feuer, tell us, what are urgent services and how are they distinguished from emergency services? Because I think that's something that parents and educators may not be familiar with.
Right. So urgent care for behavioral health is outside of the emergency department. It's a regular outpatient service. So the environment is different, the experience is different, the cost is different for families. And when they come there, they still get assessment by a child and adolescent psychiatrist. We're able to evaluate their immediate risk. We're able to come up with a provisional diagnosis of what's going on with the child and able to help them, direct them what the next step should be.
But I know, Dr. Feuer, that it could take months to get an appointment with a child and adolescent psychiatrist. Do parents need appointments for urgent care?
No, urgent care is just like any other medical urgent care, is a walk-in service. You can come without an appointment. You can reserve your spot online if you go on the website, but you can be seen the same day, and you do not require an appointment to come. And so that really helps with being able to access services at the right time when they're needed. And then we are able to help families link with the appropriate care that they need. And if there is an immediate need for help, if the child is severely depressed, severely anxious, we really feel like we need to start medication right away, we do have the capacity to do that as well and follow kids until we're able to find them care. We're also working with many schools in a similar model, supporting the school teams in a similar way. And that has been especially helpful because really supporting families from the school and from our healthcare providers, getting that mutual support can be very beneficial and can really help families connect to care sooner. That
sounds very important. What about the treatment for the suicidal youth? They come to the urgent care or they come to the ER, then what's the treatment?
So this is an interesting question. And as you know, we're just developing the research around what really is the best treatment for suicidal youth. Sometimes the suicidality is so acute and the danger is so imminent, or perhaps an attempt was even made. Sometimes kids do require an immediate safe environment, and then we do admit them to the hospital so that they can be safe and they can start treatment for the underlying illness that's causing the suicidality, whether that's a mood disorder, anxiety disorder, or whatever it may be. In that setting, they can receive that treatment immediately. Many kids don't require that. It's a very restrictive environment. And really, we don't really know whether on the long-term impact of suicidality, does inpatient hospitalization really fare better than other ways of treating kids? But
we've learned, Dr. Feuer, that throughout the country, there's an enormous variability of the percentage of youth hospitalized. In some regions, upwards of 50% of the youth who present with suicidal thoughts and behaviors are hospitalized. In other areas, it's significantly lower, including here. So what can you tell us about who gets hospitalized and who doesn't get hospitalized?
Yeah, so really, again, kids that get hospitalized are the ones that we really have no way of keeping safe outside of the hospital, and we feel like they must stay in the hospital for that reason, or kids that are so severely ill that their symptoms cannot be controlled in an outpatient environment. Most kids require immediate treatment, but not necessarily in a hospital setting. The hospital setting has its own risks and benefits, and when we evaluate kids, we really take into account so many different factors, including the family circumstances, currently available alternative treatments, what are the resources that this child has at their disposal if they go home, what are the resources we can provide them with if they go home, can we start them on medication, can we have them followed closely in our urgent care crisis clinic and then get them into outpatient treatment and have them supported that way, does that have benefits for them, are there family protective factors that maybe we can utilize better if the youth stays at home. So those are all the factors that get weighed in, and is often a very complex decision to make. We also figure out what it is that the next step that the family feels comfortable with, the youth feels comfortable with, what is their ability to engage in something called safety planning. And safety planning is really important to mention because it is a very important therapeutic tool that we use. It's not simply a contract for safety where we ask people to promise that they're going to be safe. Can you keep yourself safe? That really doesn't mean much because in the moment they might feel they can, and the minute they leave, they might feel differently. So instead, a safety plan really helps, again, foresee what problems might come. What are the things that put you in crisis? What are situations that trigger you? How does your body feel when that happens? What are thoughts that go through your mind when that happens? And when that happens, what are things that you can do to help yourself calm down? What are things that you can do by yourself with nobody else's help? Who are the people in your life that you can reach out to get distraction or help from? Who are the people that you can reach out to in a crisis? What are the alternatives? What is the most important thing in your life that is worth living for? And somebody's ability, as a patient's, as a child's ability to engage in that conversation, engage in that therapeutic planning, really tells you a lot about, are they going to be safe to be home, or are they not going to be able to even think through and go through these steps and this exercise.
I would imagine the safety planning requires parents also to feel comfortable, because even if the clinician, if you're comfortable that the child is safe, the parent may not be. So that really requires spending additional time educating the parents about the importance of the safety planning.
Absolutely, and we do go over to the safety plans. We give parents a checklist of like, well, where is my child's safety plan? And then also we explain to parents that adolescent and child suicidal behavior tends to be very impulsive. It's usually not pre-planned. It's usually decided on minutes or hours before the event. And for that reason, oftentimes it also goes as quickly as it came. And if we are able to create safe environments around children, restricting items in their environment that they can seriously harm themselves with, that is actually one of the most powerful tools that we have to protect children from suicidality. So we go in detail with parents through the very concrete elements of over-the-counter medications should be locked up. That includes Tylenol, that includes vitamins, that includes ibuprofen, really prescription medications, sharp knives, ropes, alcohol, car keys, really thinking through with them what is it in their home environment that we need to worry about, that their child might impulsively hurt themselves in, and that by sanitizing the environment and keeping a safe home, we can all help them be safer and actually feel safer. After a safety planning and an education like this, when we do together with the family and go through it with the adolescent and the parents together, kids often will say, that makes me feel so much better knowing that I'm not gonna have anything to hurt myself in, knowing that my parents are prioritizing my safety and my well-being and are gonna do what it takes to keep me safe.
So how do we guide parents and educators, but I think primarily parents, to take seriously comments about depression, suicidal thoughts from their youth? Because I've heard, and I imagine you have as well, many situations where the kids have actually expressed these kinds of concerns, and the parents have either minimized them, not taken them seriously, or even responded by saying, you have nothing to be depressed about. And so how do we guide parents to take these concerns seriously?
I mean, I think it's just outlining how wide the problem is and how important it is to address it, and that it always means something. So, you know, let's say your child says some sort of suicidal statement, and you know your child, you know they're not depressed, you know that they've been actually well, and you think it was just something to say. Still, it's really important to explore why they said that, and if there was really nothing underneath, teaching them that it's really not the appropriate way to express frustration, that these are not the words we use to say when we're upset about something or we're frustrated about something. And most times when you start a conversation, you might discover that there was something underneath. And those really have to be taken seriously. And the emotions have to be kids' experience and how they feel. It's their experience. There's no way in changing that. Us saying to, you know, you need to calm down, or what do you have to depressed for, is only gonna make kids feel worse.
Well, in fact, I've heard many parents say, I know how my child feels, and actually I usually say, well, actually no one knows the way your child feels better than him or herself or themselves, and the truth is that parents need to know that kids can have these feelings that they may not be aware of. Absolutely. And to take it seriously. Now, I know a moment ago you talked about how parents can help to make this home environment safer with safety planning and education. But finally, what are the take-home messages for parents? What should parents and educators do when the child or adolescent is reporting suicidal thoughts?
They always have to be explored. They can never be dismissed and invalidated. And a lot of the times, an evaluation might be necessary by a mental health provider, because really to assess the full factors that might be influencing that statement or might be leading to that statement and what is underneath it, you do need that assessment. And so evaluating each concern is really important, and addressing it is really important. Never let it go dismissed. Never, you know, have it be unheard.
Right. So I really want to thank you for your comments. I know that parents and educators and others who have been listening to the program may have further questions. We'll have our contact information posted, and I imagine people may reach out with information, but certainly the goal for the presentation is really to help educate parents and educators in the community about the importance of taking concerns about mental health seriously, in particular suicidal thoughts, and once again reiterating that there is no health in anyone without mental health, and that we really have to recognize the importance to continue to destigmatize this, to recognize the importance of taking it seriously, and when there are mental health concerns, to helping children and families to seek the appropriate care. So I want to thank you, Dr. Feuer, for your comments and for your efforts. I thank the audience for listening, and we certainly are available to you for further questions, and we look forward to hearing from you. Thank you.
Thank you so much.